Oral environment and patient considerations. To become effective in the selection, manipulation, and handling of dental materials, it is important that the auxiliary have an appreciation for the complexity and challenges of the oral environment. Dental biomaterials placed and used within the oral cavity must be biocompatible, durable, non-reactive under acid or alkaline conditions, compatible with other materials, and aesthetically acceptable. Eating by itself introduces hot and cold extremes, acidic or alkaline foods and beverages, hard or sticky foods, and heavy biting pressure. These factors may degrade the materials over time, affect marginal integrity, roughen the surfaces, or fracture the restorative materials. Materials must be selected that have physical and mechanical properties that can hold up in these conditions. The severity of the conditions in the oral environment may vary somewhat from patient to patient in specific circumstances. The degree of compatibility may depend on how or how long the material is expected to survive in the oral environment. Therapeutic materials, those used to treat disease, are generally used for short periods of time, whereas restorative materials, those used to reconstruct tooth structures, are expected to remain in contact with tissue for indefinite lengths of time. Consider the following cases. If a therapeutic agent were to be used to treat a specific condition, such as a denture sore, it would need to be biocompatible with the tissues, but would not need to last long. If the material were being used as a permanent restoration, such as a gold crown, biocompatibility and longevity would both be required. Patient concerns, questions, and demands must also play a part in the decision process. The patient should be brought into the decision process very early. Tooth-colored materials are frequently requested by the patient, but may present limitations in their use under certain circumstances. Patients are frequently looking for the best aesthetic choice and may not be aware of the limitation of that choice. The patient may desire porcelain or composite veneers to cover discolored anterior teeth or to close spacing. If the patient has parafunctional habits such as clenching or grinding, the choice of porcelain may result in chipping or wearing of the opposing teeth or the restorations themselves. On the other hand, composite veneers may wear down excessively under the same conditions. The patients need to be educated as to the limitations imposed by their particular oral conditions and the appropriate restorative choices in order to produce long-lasting results. The auxiliary is frequently involved in the education and must have a good understanding of how materials function in the oral cavity. Classification of dental materials. Dental materials may be classified by their use: preventive, therapeutic materials, restorative materials, and auxiliary materials. Preventive therapeutic materials. These are used to prevent disease or trauma or for their therapeutic action on the teeth or oral tissues. Included in this category are materials such as pit and fissure sealants to help prevent caries, mouth guards to mitigate the effects of parafunctional habits and injury due to athletic activities, and materials used for their antibacterial effects such as those found in some restorative and base materials. Also included in this category are fluoride and fluoride-containing materials to prevent or reduce the progression of caries. Restorative materials. These include those materials used to repair or replace tooth structure lost to oral disease or trauma or to change the appearance of the teeth. Restorations are classified as direct and indirect. Direct restorations are placed immediately and directly into a prepped tooth in a pliable state that then sets to harden. This procedure can be done in a single office visit. Indirect restorations involve customized tooth replacements that require fabrication outside the mouth, usually in a lab. These restorations usually require a second appointment to fit and cement the restoration. Auxiliary materials. These include those materials used to fabricate and maintain restorations, directly or indirectly. Materials such as impression materials, gypsum, dental waxes, and finishing and polishing materials are also included in this category. Biocompatibility. Materials must be biocompatible. That is, they must not impede or adversely affect living tissue and should interact to the benefit of the patient. The study of dental biomaterials must include a thorough understanding of each material's biological properties. All materials contain potentially irritating ingredients. Responses may include postoperative sensitivity, toxicity, and hypersensitivity. A material may be acceptable for use or fabrication on hard tissues, tooth structures, whereas it may not be acceptable for the use on soft tissues. Some materials may be therapeutic in small quantities or if in contact with tissues for short periods of time, but also may be irritating or toxic with longer contact or in larger quantities of higher concentrations. Topical fluoride is of great benefit when used according to the manufacturer's directions, but can be irritating to soft tissues and even excessively etch enamel if an acidulated version is used. Dentistry is not alone in its attention to the development of biocompatible materials. Orthopedics must consider biocompatibility in the placement of joint prosthesis, as does cardiology in the placement of catheters and prosthetic heart valves. All must consider the short-term and long-term functional and biocompatible responses of any material. Postoperative sensitivity is often associated with the dental operative procedures. This may be due to the toxicity of the restorative, preventive, or therapeutic material or bacterial invasion into or near the pulpal tissue. Adverse responses. A patient may have an adverse response to a dental material. The response may be due to the material itself or may be due to breakdown products of the components in the oral environment. An example of an adverse response is seen with patients allergic to some metals, particularly nickel. There is evidence of nickel allergies in 10 to 20% of the population, particularly in women. It is thought that they become sensitized to nickel by wearing jewelry containing it. Some nickel-containing alloys are used in dentistry for fabrication of crowns, bridges, partial denture frameworks, or in orthodontic wires. Evidence of allergic reactions to nickel may be seen as crown margins or metal-based crowns on a patient's lips when wearing some orthodontic appliances and on the patient's attached gingiva in contact with metal framework of a removable prosthesis. A complete health history, questioning of the patient, and a thorough examination of oral tissues can help to identify hypersensitive individuals. Frequently, several different materials are used in combination to produce a restoration, such as porcelain fused to metal crown, cemented with glass ionomer cement. The use of multiple materials makes it more difficult to determine which material is responsible for the adverse response. In general, materials intended for permanent replacement of the tooth structures should exhibit no adverse biologic responses, as well as be of benefit to the patient. In subsequent chapters, the limitations as well as precautions for the use of each material will clearly be outlined. Oral factors affecting dental materials. A number of factors in the oral environment will have an effect on the functioning and durability of the dental materials used in the oral cavity and thus will have an influence on which material the clinician will select. Biomechanics. The function of material depends on the physical and mechanical properties. Physical and mechanical properties of dental materials, of that material, as well as on how the material is being asked to perform. Designs for restorations require an understanding of the biomechanical properties of the material. Much like an engineer, the dentist must design a dental bridge by taking into consideration the load that will be placed on the bridge, the length of the span, and the stability of the supporting structures. For example, a material may be used successfully to restore anterior teeth where biting forces are not as strong, whereas the same material may be undesirable to restore the occlusal surfaces of posterior teeth where biting forces are heavier. Excessive wear of a material may occur when a stronger material applies force against a weaker material, such as porcelain against composite resin, and may be intensified by surface roughness on the porcelain and by parafunctional habits such as clenching or grinding. Dentists must consider the performance of a material based on a thorough knowledge of the material's properties, the intended application of the materials, and the impacting factors in each patient's oral cavity. Force, stress, and strain. Force. A force is a push, pull, or twist, or a combination of these, applied to a material. When a weight is placed on an object, the weight applies force to that object. The force applied at the surface creates stress within the object that tries to resist the weight. If there was no resistance to the weight, then the material would be flattened or displaced. Materials used to restore teeth must withstand varying degrees of force or load applied through muscular action, resulting in the pushing or pulling of the restoration by the teeth or food bolus during mastication. For some patients, the forces come from parafunctional habits such as clenching or grinding, called bruxism. Normal biting forces varies among individuals and from one area of the mouth to another. Biting force is largely a measurement of the strength of the muscles of mastication and the surface area which the force is applied during the normal chewing of foods. When clenching and grinding, this force is increased due to the lack of food cushion and the resultant direct contact of two surfaces. Normal masticatory forces on the occlusal surfaces of molar teeth average 90 to 200 pounds per square inch and can increase as much as 28,000 pounds per square inch on a cusp tip. Masticatory forces are greater in the molar region and gradually decrease moving toward the anterior part of the mouth from premolars to incisors. Denture wearers apply 40% less force than patients with intact dentition, but denture wearers whose dentures are supported by implant or roots regain much of the biting force. A study of the anatomy of teeth reveals that each kind of tooth shape, incisor, premolar, molar, is designed to apply specific types of force. The three basic types of force are as follows: compressive force, tensile force, shearing force. Compressive force. This is force applied to compress or squeeze an object, crushing, biting forces. Posterior teeth are ideally suited for this type of force. Their large occlusal surfaces and multi-rooted bases are well suited to resist a crushing force. Tensile force. This is force applied at each end of the material in opposite directions to stretch an object or pull it apart. When tensile force is applied to a rubber band, it is stretched. Shearing force. Force applied when two surfaces slide against each other in opposite directions. When the maxillary and mandibular incisors are used for cutting, shearing forces are applied. When we use the anterior teeth to bite into food, we slide the mandibular teeth forward or to the side across the maxillary teeth to shear it off. Torsion. Another type of force is torsion or torque. It is a twisting force that has tensile and compressive forces. This force is more descriptive of normal masticatory events. When we chew, we combine compressive, tensile, and shear forces, resulting in torsion. When a patient wears full dentures, he or she may complain that dentures become dislodged when they chew certain foods. This is because of the torque of the dentures, which are not well suited to withstand the combination of compressive, tensile, and shear forces while eating. The forces used in chewing a sticky caramel candy are different from those used in chewing a peanut. The caramel is compressed as the person bites down and sticks to the teeth. Then it is torn apart by tensile forces as the jaws separate. The peanut is crushed by compressive forces and ground with shearing forces as the upper and lower posterior teeth slide across each other in a chewing cycle. Flexure. Flexure or bending force is a combination of compressive, tensile, and shear force. When a long plastic rod is flexed into an arch shape, compression occurs on the inside surface of the arch, and tension occurs on the outside of the arch, while shear occurs inside the rod itself. Stress and strain. When a force is exerted on a tooth or restorative material, the tooth or material creates stress to resist the force. Stress is expressed as pounds per square inch or megapixels in the metric system. If an object is fixed in position, it may be deformed by the force if the magnitude is great enough and the object is considered strained. Stress, then, is the amount of force exerted from within an object to resist an external force, and strain is the amount of change that the force has produced in the object. When the strain is caused by compressive force, the object is shortened while tensile force causes the object to lengthen. If the object does not return to its original shape after the stress is removed, it has undergone permanent deformation. If the object returns to its original shape, the change is called elastic deformation. The effect of the object is determined by the size of the force, the point of the area of contact, and the direction in which the force is applied. If a force is applied over a large surface area, the stress generated is less than if the same force is applied to a small area. The large surface area helps to dissipate the impact of the force. Stress-strain curve. Each material has its unique relationship between stresses placed on it and strains that develop in reaction to those stresses. The relationship is known as the stress-strain curve. The curve is determined by plotting the amount of deformation that occurs at each magnitude of applied stress. It is useful in comparing how materials can withstand loading. Thus, it can help in selecting an appropriate dental material. For example, to use in restoring the biting surfaces of the lower molar. It can show which material is strong enough and stable enough for that application. The normal process of chewing really involves only one type of stress. Complex stress combinations are more common. For example, dental bridges are subject to flexural stress when compressive forces placed on the occlusal surface of the bridge bend the bridge downward and the tensile forces of the tissue side of the bridge stretch upward in response. Materials may be suited to one type of stress but fail during another. If the force is exerted over a large area, the tooth structure may more adequately handle the stress. When the force is exerted over a small area, the increase in pressure may result in a fracture. Consider the force exerted on the floor by a woman wearing flat shoes and then changing into high spike heels. The woman's weight supported by both types of shoes is the same, so there is no difference in force. However, because there is a difference in area, the pressure on the surface contacted is drastically different. This is the reason that teeth of restorations may fracture when subjected to stresses by small, very hard objects such as popcorn kernels or cherry pits. Fracture toughness strength. Fracture toughness is a mechanical property of materials that measures the energy needed to fracture a material. When increasingly higher forces are applied to a material, it will eventually fracture, and the point of fracture is called the ultimate strength. Resilience. Resilience indicates the energy needed to permanently deform a material. Brittle materials such as composites, amalgams, or ceramics are not resilient and do not deform readily and will fracture if loaded too much. Any flaws in the materials will cause stress to concentrate in those areas and ultimately reduce the strength of the material, leading to fracture. Values of compressive and tensile force applied to this two structure and restorative materials are expressed in a table above. Use the table to compare the ultimate compressive and tensile strengths of two structures types to the various restorative materials to understand why a certain material may function better in one application than another. As you can see, amalgam and composite resins more closely replicate enamel in compressive strength, whereas porcelain falls short. Porcelain is brittle and more likely to fracture under compressive stresses, especially those that are directed into a small area. Note, porcelain is one type of ceramic material described later on. It is one of the weaker ceramic materials, but is very aesthetically pleasing. Fatigue failure. During mastication, stresses occur repetitively over time. Failures rarely occur in a single force application. Rather, they occur when a stress is frequently repeated. These repeated stresses may produce microscopic flaws that grow over time, resulting in fracture. This is known as fatigue failure. A metal wire bent repeatedly will eventually break. This is another example of fatigue failure. Teeth and restorative materials under functions of bruxism are subjected to repeated stresses by a mixture of forces applied in a variety of directions and intensities. As a result, they may crack or fracture. Additionally, conditions of the oral cavity such as moisture, temperature, and pH fluctuations may also contribute to fatigue failure. Moisture and acid levels. The oral cavity is always in contact with moisture in the form of food, saliva, and blood. This moisture can vary from acidic to alkaline depending on foods, beverages, medications, and the amount of acid-producing bacteria present, biofilm. The effect of the pH. The normal resting pH of saliva ranges from 6.2 to 7.0, that's neutral, but can fluctuate higher or lower by several points during the course of a day. Many materials that would be compatible in a neutral environment will not be compatible in an acidic one. Some beverages are slightly or very acidic. Citrus, fruits, and sports drinks contain citric acid and can attack enamel and some restorative materials. Acidulated topical fluorides can also attack some materials such as glass ionomer, cements, composite resins, and ceramics. Most materials are adversely affected by moisture, either during placement or in the long-term clinical behavior of the material. The breakdown of many restorative materials is directly related to the effects of moisture, acid, and stress. Materials designed for long-term retention in the mouth must not readily deteriorate under these conditions. Solubility. Desirable materials should have low solubility, that is, not susceptible to being dissolved in a solvent. And in the case of the oral environment, saliva is the main solvent. Gold and porcelain are retained in the oral environment for many years because of their insoluble nature. Glass ionomer cement materials, frequently used as tooth-colored restorations, are much more soluble. They tend to wash out or change in mass over time, requiring replacement. Water absorption. Some materials also have the undesirable characteristics of water absorption, or the ability to absorb moisture. This may result in staining or a slight swelling of the material. Staining of resins and acrylics, repeated exposure to coffee, tea, and other dyed beverages is due to water absorption. Dentures placed in a glass of water will take up the liquid and become slightly larger. Some acrylics will absorb both odor and taste from foods due to microscopic porosities in the material. Directions on routine home care can help alleviate this problem for the patient. Corrosion. Metals suffer from the effects of moisture and acidity, with the exception of noble metals such as gold and platinum. The deterioration or dissolution of the metal in response to a chemical attack, acid, or an electrochemical reaction with other metals because of the moisture and acid present in the oral environment is called corrosion. Metals such as steel cannot be used in the oral cavity because the metals break down in the wet environment, becoming iron oxide, commonly known as rust. When steel is coated first with a barrier to corrosive components, the barrier gives steel its stainless quality. Dental amalgams are particularly susceptible to corrosion, causing marginal breakdown and discoloration of tooth structures. The result of corrosion is also seen on dental instruments that are processed in autoclaves due to oxidation of the metal surfaces. Corrosion begins at the surface of the metal and migrates deeper into the metal than tarnish. That is limited to the surface and can be seen as discoloration. Corrosion can accelerate into the crevices between tooth and restorations and on the rough surfaces. Polishing of amalgams to produce a smooth surface has been recommended to help delay this process. In high copper amalgams, this may not be as critical to their longevity since they are more corrosion resistant than low copper amalgams. Galvanism. An environment containing moisture, electrolytes, and dissimilar metals makes the generation of an electric current possible. The ions in the saliva facilitate the movement of electrical current from one type of metal to the other. The phenomenon of electric current being transmitted between two dissimilar metals is called galvanism. The current may result in stimulation of the pulp, called galvanic shock. The classic example of a metal fork touching a metal restoration or the biting of an aluminum foil will be familiar to anyone with metal restorations and unfamiliar to those who have no metal restorations. Some patients may even feel a galvanic shock or report a metal taste when instruments are used against the surface of a restoration. When it becomes necessary to place differing types of metal restoration, such as gold crown, in contact with an amalgam restoration, insulation under the restoration in the form of bases or liners can help lessen the stimulation. Provisional temporary aluminum crowns placed opposite of adjacent to amalgams or metal crowns can also cause this phenomenon. In this situation, the selection of a polycarbonate or acrylic provisional crown would be a better choice. In time, the galvanic stimulation will fade as oxides form on the surface of the metal, acting as an insulator against the galvanic current. Temperature, expansion, and contraction. The ingestion of hot and cold foods and beverages and smoking may alter the temperature of the oral environment. With few exceptions, all forms of matter expand when they are heated and contract when cooled, resulting in dimensional change. Atoms or molecules in a material vibrate over a greater range when the material is heated, causing it to expand. Acceptable materials used as restorations and replacement of tooth structures should have characteristics of expansion and contraction similar to tooth structures. Excessive expansion of a restoration within a tooth may result in fracture of cusp. Excessive contraction may result in leakage of fluids and bacteria into open gaps, resulting in sensitivity. Expansion and contraction are measured as the coefficient of thermal expansion, CTE, the measurement of change in volume or length in relationship to change in temperature. Amalgam readily heats up and expands or cools and contracts with small temperature change, whereas composite resin is not a good conductor of temperature and requires a greater temperature change to expand or contract. Both of these materials have rates of expansion and contraction that differ significantly enough from enamel and dentin that the marginal integrity of the restoration may be compromised. The difference in CTE value of unfilled acrylic and sealants with tooth structures is the highest, and the value of gold is the closest to human teeth. Repeated shrinkage and expansion of a restoration during ingestion of cold and hot fluids and foods produces the opening and closing of gap with movement of oral fluids between the restoration and tooth surface, a phenomenon called percolation. Percolation allows the ingress of bacteria in oral fluids and may lead to recurrent caries, staining, and pulpal irritation. Thermal conductivity. Thermal conductivity is the rate at which heat flows through a material over time. Enamel and dentin are poor thermal conductors, whereas metals are excellent conductors. Gold is one of the best thermal conductors, even better than amalgam. Non-metals such as ceramics, composites, acrylics, and cements are very poor conductors. Poor conductors can be used as restorations or as insulators. For instance, a patient wearing a denture may not sense the temperature of a liquid because of the insulation produced by the acrylic denture base. When a metal restoration conducts temperature changes into the tooth from foods and beverages taken into the oral cavity, the pulp of the tooth may feel the resultant stimulation as sensitivity, particularly in the overlying dentin is thin. Dentin acts as a natural insulator, but when it is too thin, temperature changes may be felt by the pulp. Amalgam and gold have much higher values of thermal conductivity than dentin and enamel. A hot cup of coffee may transmit heat readily through these metals, resulting in pulpal stimulation. A piece of ice placed on an amalgam restoration may conduct stimulation to the pulp in as little as 2 to 3 seconds. When metal restorations are placed close to the pulp of the tooth, material such as a cement is often placed between the tooth structure and the restoration to act as an insulating base to delay and absorb the transfer of temperatures. Metals placed against tissue, such as partial denture framework and some orthodontic appliances, can also conduct temperature to the soft tissues. Compare values for restorative materials with those for tooth structures to determine the potential for marginal leakage through percolation and or the need for insulation. When there is a large difference between the CTE for the restorative material, such as amalgam, and that of the tooth structure, the percolation will be greater. Note that whereas composite has a higher CTE compared with tooth structures, bonding it to the tooth structure helps to prevent percolation. In addition to temperature considerations for materials already present in the mouth, it is important to consider the temperature of materials as they are placed in the mouth. Icy cold water used when mixing alginate may cause the patient's pain when the very cold alginate contacts metal restorations. The components of some materials when mixed may result in a chemical reaction that produces heat. For example, when the powder and the liquid of a chairside denture realigned materials are mixed, the reaction produces heat, an exothermic reaction. If the material is left in the mouth while this reaction is occurring, it is possible that the tissue could receive a thermal burn. Retention. An important factor in the selection of materials, how it will be retained within or on the tooth. The retention of material is its ability to maintain its position without displacement under stress. Retention may be secured through mechanical, chemical adhesion, or bonding mechanisms between materials. Mechanical and chemical retention. Mechanical retention involves the use of undercuts or other projections into which the material is locked into place. The undercuts used in typical amalgam preparations are an illustration of mechanical retention. Note that the opening of the cavity preparation is smaller than the internal floor of the preparation. Once the material is hardened in place, it is retained through this design. When a significant amount of tooth structure has been removed, undercuts no longer be successfully used because the cusp of other parts of the tooth will be undermined and weakened. At this time, the clinician may wish to place a restoration covering the remaining tooth structure, such as a crown, and hold it in place with a dental cement. Dental cement retains the restoration by chemically and or mechanically connecting the tooth surfaces. Glass ionomer cement will chemically bond to the mineral component of the tooth structure and can also mechanically retain a crown. Bonding. Bonding is a term commonly used when describing the retention of materials. Bonding of materials occurs when the tooth structure is prepared with an acidic etch technique to create microscopic roughness and pores in the enamel and dentin. A fluid bonding material is then allowed to flow into the roughened surfaces and pores, and when hardened, is mechanically locked into the tooth structure. Restorative materials that adhere chemically to the bonding materials are then placed. This technique offers several advantages in producing retention. It requires less removal of healthy tooth structure because no undercuts are necessary. It produces a stronger retentive force between tooth and restoration, and it can seal the margin of the restoration to prevent the seepage of bacteria and fluids through percolation. Many of today's restorative materials use combination of mechanical and chemical or bonding adhesion for optimum retention. Retention by mechanical undercuts alone will not adequately seal the margins of a restoration and will frequently place tooth structure in a jeopardy of fracture when undercuts leaving vulnerable areas of tooth structure is unsupported. Bonding requires the intimate contact of surfaces to produce the best bond strength. The strength of the bond is measured by applying shearing and tensile stresses. Factors affecting bond strength. Several factors can affect this bond strength and the success of material as an adhesive. These include wetting, viscosity, film thickness, and surface characteristics of the tooth restoration and adhesive. Wetting. Wetting is the degree to which a liquid adhesive is able to spread over the surface of a tooth in restorative material. This wettability is based on the contact angle between the liquid and the tooth surface. The lower the contact angle, the better the liquid adhesion spreads onto the tooth surface. The Teflon surface of cooking equipment exhibits poor wettability. That is, the liquids bead up on the surface rather than spreading out. The better the adhesive is able to spread on the surface of the tooth in restoration, the more retentive it is. Microscopic surface roughness, such as that creating by etching enamel, will increase the wetting of the surface by the liquid. Viscosity. Viscosity, that is, the resistance of a liquid material to flow, can hinder the ability of a liquid to wet a material. Materials with high viscosity are thicker and do not flow well, and therefore may not be effective in wetting an area. Viscosity can also affect the film thickness of an adhesive or a cement. Film thickness. Film thickness is the minimal thickness obtainable by a layer of liquid material after it sets under pressure and is particularly important in working with dental cements. When cementing a crown, if the film thickness of cement is too great, it may keep the crown from seating completely. A thin film of cement is desirable to allow the cement to flow from the under the crown when it is seated under pressure during cementation. Surface characteristics. Surface characteristics are other factors that affect the adhesive retention of a material. They include the cleanliness of a surface, moisture contamination, surface texture, and surface energy of the restoration and tooth. As mentioned previously, adhesion depends on the intimate contact of surfaces. Even slight contamination can prevent contact. Debris from other tooth preparations, microorganisms in biofilm, and products of saliva are often impossible to completely eliminate. Surface irregularities may prevent complete wetting of the surface. Microscopic surfaces irregularities can trap air as the adhesive flows over them, resulting in incomplete wetting of the surface. Surface energy. The surface energy of liquids is also called surface tension. The molecules of the surface of a liquid or a solid are aligned differently than in the center. In the center of the molecules are the balance with the molecules that surround them. At the surface, however, there is an imbalance in the attraction between molecules, causing them to be attracted to the larger mass of molecules in the center. This attraction of force directed inward causes an energy level at the surface. With liquids, if the surface energy is high, the liquid can flow readily over a solid substrate. When liquids beat up on a surface, such as wax on many plastics, the surface has low surface energy. Solids also develop surface energy. When enamel is etched, a high surface energy is created that can attract liquids across the surface. If newly etched enamel comes in contact with just a little saliva, a molecular film of saliva is drawn across the surface by the high energy, causing contamination. Liquids generally wet or spread over high surface energy surfaces better. Metals, ceramics, and enamels have high surface energies. Many situations present conditions that are not favorable for retention of materials. The dentist is responsible for the mechanical design of the preparation, but is not solely responsible for other factors. In many states, allied oral health practitioners routinely place therapeutic and restorative materials. In addition, the dental assistants play an essential role in delivering materials and controlling the conditions of the oral environment during their delivery. An understanding of the factors that influence retention is essential to achieving a successful restoration. Microleakage. The need for replacement of restorative materials can be significantly influenced by microleakage. The surface between the walls of the tooth structure, preparation, and the restoration is called the interface. If this tooth restoration interface is not sealed, there may be a space into which fluids and microorganisms can penetrate. The seepage of harmful materials is called microleakage, and it is responsible in part for recurrent decay, marginal staining, and postoperative sensitivity. Microleakage may be due to deterioration of dental materials, percolation due to the differences in CTE, or lack of adhesion of the material to the tooth. It is easy to understand why the seepage of bacteria and other fluids between preparation and restoration sets up an environment for recurrent decay and staining. Postoperative sensitivity may be due to microleakage as well. Tubules found within the hard material of the dentin are filled with fluids under pressure from the pulp. When the enamel of the tooth is removed, fluids can flow out of the much larger dentinal tubules, and outside chemicals and bacteria can flow in, causing irritation of the pulp and sensitivity. Procedures for ensuring the proper seal of dental tubules are described later. Aesthetics and color. Aesthetic dentistry is rapidly growing elective procedure which is in high demand and may be equal, if not greater, concern to the patient than function. Our eyes sense light through the cone cells in the retina, 3 different ranges of wavelength, red, green, and blue. Having 3 types of color sensing cells doesn't limit us to just 3 colors. The stimulation of 2 or more types of cone cells, the amount of light they detect, and the interpretation of that light by our brain determines the overall response to a particular color. Mixtures of red, green, and blue light allow you to see many colors. The television mixes these primary colors of light to produce full color pictures. 3 components, hue, chroma, and value, describe the resultant color. Hue is the dominant color of the wavelength detected. Tooth colors are predominantly seen in the yellow and brown range. Chroma refers to the intensity of strength of the color. Teeth are rather pale in color. Value describes how light or dark the color is. Teeth have a value ranges at the light end of the value scale. As we age, the tooth value gets darker. The color of teeth in ceramic and composite resin restorations is influenced by the optimal properties. Light that reaches the surface of the tooth or the restoration can be transmitted through it, absorbed by it, and scattered or reflected by it. If light passes directly through an object like window glass, it is transparent. If light is completely absorbed, scattered, and or reflected by the object, it is opaque. Light is reflected off the surface called reflectance, depending on the surface texture and amount of polish. Usually, teeth in aesthetic restorations will reflect light and transmit light to various degrees, giving the tooth or restoration a lifelike quality called vitality. Manufacturers, over time, have adjusted the components of composite resins so that they can absorb, transmit, scatter, and reflect light to mimic natural tooth structure. The same can be said for modern ceramics. Individuals see these many colors, components, and reflections of colors somewhat differently in different situations. This phenomenon, known as metarazism, means that colors look different under different light sources. It is important that we have a standardized measure of colors, such as a shade guide, to give us an objective measure. It is also important that we produce an environment that reduces the possibility of extraneous color reflection and producing an inaccurate color match for the restoration. Oral biofilm and dental materials. It is important to have a basic understanding of oral biofilm, what it is, how it functions in health and disease, and how to manage it to maintain healthy mouth. The oral biofilm is three-dimensional, complex, structured community of microorganisms that can be found on mucous membranes, teeth, intracoronal fillings, and extracoronal crowns, restorations, dental implants, and removable prostheses. Over 700 species of microorganisms can colonize the mouth. These microorganisms include bacteria, virus, and fungi. In any one individual, approximately 200 of these species may exist as part of normal oral microbiota. Of these, bacteria are found in the greatest numbers and species. The oral biofilm exists in a dynamic, symbiotic, beneficial to host and microorganisms relationship with the host. The biofilm provides some level of protection of the structured community of microorganisms from invading bacteria, fungi, and viruses, and toxic substances such as antibiotics or chemicals. The biofilm also provides a type of circulatory system for the uptake of nutrients derived from adjacent tissues, from salivary secretions, from other microorganisms, and from the host diet, and for the elimination of metabolic byproducts through water-filled spaces between colonies. Formation of oral biofilm. Biofilm or dental plaque forms on the teeth soon after they erupt. Likewise, it is quickly reforms after a professional cleaning and forms on newly placed restorations. The initial layer on the surface of the teeth or restoration comes from salivary and gingival crevicular fluid components such as proteins, glycoproteins, lipids, albumin, and mucin, and is called acquired pellicle. That layer acts as a base to which bacteria can attach. The majority of the first colonizers is from Streptococcus genus S. mutans, S. salivarius, and occupies up to 90% of the surface, while other early colonizers occupy the remainder. The early colonizers are mostly gram-positive bacteria. They have a thick cell wall that retains a stain used in the laboratory. Within a couple weeks, gram-negative bacteria, they have a thin wall that does not retain the stain, begin to proliferate. Later, colonizers are mostly anaerobes. They thrive where there is little or no oxygen that can contribute to periodontal disease and may attach to the growing plaque. As the bacterial community grows, the adherent bacteria forms a protective matrix from extracellular polysaccharides they secrete. The matrix can help in protecting them from competing microorganisms, antibiotics, and antibacterial mouth rinses. A state of microbial homeostasis, a stable state of equilibrium, forms until it is thrown out of balance by factors affecting the oral environment, such as change in the host immune system, dietary changes, or other systemic changes. Oral factors such as temperature of the oral cavity, the pH of the saliva, and available nutrients affect the rate of growth of bacterial plaque. The temperature can change rapidly with the introduction of hot and cold foods in the beverages. The pH can vary from its normal range of 6.5 to 7.5 by the introduction of sugars that are metabolized by certain bacteria with resultant acid production. Acidic and alkaline foods can also alter the pH, but the saliva dilutes and buffers the food so that gradually the saliva returns to its normal range. This pH balancing may not happen in patients with dry mouth or saliva with low buffering capacity. Biofilm and oral disease. Most of the bacteria in the biofilm are harmless, but pathogens are present in small numbers. If systemic or oral conditions changes, the potential exists for certain pathogens for both the tooth decay and periodontal disease to proliferate and cause disease. Changes in the diet to consumption of foods high in sugars and fermentable carbohydrates can cause a proliferation of acid-producing and acid-tolerant bacteria such as mutans type streptococci and lactobacilli. These bacteria can cause dental caries. Changes in other oral cavities can cause the growth of periodontal pathogens leading to gingivitis, periodontitis, and periimplantitis. Probiotics. Prescribed antibiotics can kill beneficial bacteria as well as pathogens. It can then be a challenge to maintain a healthy level of beneficial bacteria in the mouth and gut. Numerous studies have shown that the introduction of beneficial bacteria called probiotics can help. Probiotics are live microorganisms that are consumed by an individual to promote health. The bacteria are added to milk, yogurt, and sour cream or are available as tablets, capsules, or drops. Probiotics are becoming more popular as a way to increase the numbers of helpful bacteria to the GI tract and even the mouth. By increasing the numbers of beneficial bacteria, they can help suppress the harmful bacteria. They help promote a healthy digestive tract and immune system. Studies conducted over the past 15 years have shown beneficial oral effects in managing dental caries risk by reducing mutant streptococci and plaque in saliva, in managing periodontal disease risk by reducing periodontal pathogens and thereby reducing bleeding on probing and gingival bleeding, by managing periimplantitis risk and by reducing the numbers of candida, a common fungus in the mouth that causes thrush, by inhibiting its growth. As more evidence is made available and guidelines are established on dosage and types of bacterial species to use for specific oral diseases, it is anticipated that general dentists and specialists will begin to use probiotics on a routine basis for management of these diseases. Biofilm and systemic diseases. More and more research studies are showing a correlation between periodontal disease and certain systemic diseases such as heart disease, diabetes, some respiratory ailments, and certain complications with pregnancy. It is believed that the ulceration of the gingival sulcus caused by the bacteria in the subgingival plaque allows pathogenic bacteria to enter the bloodstream and affect distant organ systems. Biofilm on dental materials. Biofilm or dental plaque on oral structures is well documented as having a primary role in the formation of dental caries and periodontal disease. The role of biofilm adhesion on the dental material is less well known. Surface roughness has a direct correlation with biofilm accumulation. Roughness from abrasion, coronal polishing agents, hand and ultrasonic scaling, and lack of finishing or smoothing and shaping, and polishing after fabrication of or initial placement of a restoration are all associated with increased biofilm accumulation. Biofilm accumulation at the margins of rough and faulty restorations may in part contribute to the development of recurrent caries. Biofilms do not accumulate as readily on polished cast alloys and ceramic restorations, possibly because of their smooth surface. Amalgams tend to have a biofilm that is less active, likely because of the effect of mercury on the bacterial population. Control of biofilm accumulation on dental implants has been shown to play a significant role in the ultimate success of the implant. Fluoride-releasing materials found in some restorations can counteract the acids produced by biofilms. Dentures tend to develop a biofilm that is high in candida, a yeast, and is associated with chronic irritation of the underlying oral mucosa known as denture stomatitis. Occasionally, the denture stomatitis requires treatment with antifungal medication to clear it up. So prevention is the best treatment. Managing the oral biofilm. Currently, we do not have a means of total eliminating pathogens in the oral biofilm, but we can manage the biofilms so that a healthy mouth can be maintained. The American Dental Association recommends twice daily brushing and flossing as basic minimum oral hygiene routine. Toothbrushing with a fluoride-containing paste can be accomplished with manual or power toothbrushing. Interdental cleaning is commonly done with dental floss, but a variety of other aids are available such as toothpicks, balsa sticks, interproximal plastic cleaners, oral irrigators. Additional oral hygiene measures may include tongue brushing or scraping. The ADA accepted antimicrobial mouth rinses, especially those with a combination of essential oils, Listerine or chlorhexidine, Paradex, can be helpful in managing gingivitis and supragingival plaque. It is important for denture wearers to clean their dentures daily with a denture brush and non-abrasive paste, and use a denture soak to remove the adherent biofilm. Detection of restorative materials. Oral health care professionals must be able to identify restorative materials within the oral environment to treat them appropriately. Heavy pressure during scaling, the use of sonic and ultrasonic scaling, or air polishing, air polishing, stream of fine or abrasive particles to smooth the surface, and inappropriate use of polishing agents may gouge or scratch the surface of the restoration. The placement of therapeutic agents such as acidulated fluoride may etch the surface of the restoration. Identification of restorative materials, which may be obvious with amalgam materials, may also be difficult when identifying tooth-colored materials such as composite resin or ceramics. In addition, restorations may be composed of different materials such as ceramic inlay cemented with resin-based cement. Identification of restorative materials may be appearance, location, tactile sensitivity, and radiography. A well-matched tooth color restoration may be difficult to distinguish from natural tooth structure. Well-developed tactile sensitivity skills with a dental explorer, adequate illumination, liberal use of air to dry the teeth and restoration, and even a magnification may be needed to detect some aesthetic restorations. The location of margins, especially those placed subgingivally, make visual inspection of many materials impossible. Drying the teeth well often makes the detection of composites easier. Saliva tends to hide the distinction between the tooth surface and the margin of the restoration, as well as the differences in the textures and luster, shininess of the restoration surfaces. Tactile evaluation of the tooth surface can be a helpful means of clinical assessment. The surface of some composite and glass ionomer restorations may feel rougher than enamel. Tracing the enamel surface onto the restoration with a sharp tip of an explorer is the best way to distinguish the difference. The clinician may detect a smooth surface on the enamel and a scratchy surface on the restoration. This difference may be noticed at the cavo surface margin, the margin of the cavity preparation that meets the tooth surface. Once the presence of the restoration is identified, the entire cavo surface margin should be evaluated. The cavo surface margin should be almost undetectable as the tip of the explorer passes from the restoration to the tooth. Sealants have a smooth, glassy surface covering the anatomical pits and fissures of the tooth surfaces. The explorer feels like it is skating on ice. Porcelain has a very smooth, glassy surface, and the explorer glides easily over the surface. Note the tip of an explorer as it glides against the margin of the restorations. Adequate direct illumination and transillumination are helpful for detection of many anterior restorations. With transillumination, light can pass through the teeth to varying degrees based upon the intensity of the light and the thickness of the teeth. A mouth mirror placed in lingual to the incisors can reflect the operatory light through these thin teeth. The light will not pass through the restoration as well as enamel, so it will stand out. This, along with the knowledge that most anterior restorations are prepared from the lingual surface to preserve as much natural enamel on the facial surface as possible, will help in the identification of many Class 3 and 4 restorations. Magnification and liberal use of air will help to distinguish the glossy surface of enamel versus the more opaque surface of composite resin restorations. However, highly polished newer generations of composites allow them to be polished to very smooth, lustrous surface similar to enamel. Radiographs are a valuable tool for the detection of restorations and assessment of restorative components. Most modern composites are radiopaque, but some older ones are radiolucent. Glass ionomers are radiopaque, as are many resin-based cements and ceramics. Note that we'll skip over that. For most difficult to detect restorations, it is necessary to use a combination of the above described methods to determine the presence and types of materials before clinical procedures are performed. The summary: the oral environment presents unique challenges to successful use of dental materials as restorative and therapeutic agents. An understanding of the limiting factors in this environment and an appreciation for how these limitations affect the selection of materials are essential to those successful use of dental materials. Materials used must be biocompatible, exhibit long-term clinical durability, and be aesthetically acceptable. No one material is superior in all the areas. The allied oral health practitioner must have an understanding of the limitations as well as a criteria for selection of therapeutic and restorative materials. With this knowledge, he or she can educate the patient about the materials used in their mouths as well as select and properly manipulate and maintain materials to ensure their ultimate success.